Hello, my name is Cassandra Doyno, and today I will be discussing the results of research titled Evaluation of Time to Administration of Prothrombin Complex Concentrate Following Implementation of a Dosing Pilot. Hematoma expansion is a major cause of mortality related to vitamin K antagonist-associated intracranial hemorrhage. Prothrombin complex concentrate, or PCC, is a For pharmacy specifically, we identified multiple barriers that directly affected time from order to administration. First, the entire ordering and verification process was restructured. Before explaining the workflow, I'll explain the dosing units of the product of 4-PCC which we used. Since it is pooled factors, the dosing unit that is assigned to it is based off of factor 9 units. Each box or vial of 4-factor PCC has a specific unit amount of factor 9, which accounts for variance, and can contain between 400 and 620 units of factor 9. Prior to pilot implementation, the verifying pharmacist would receive an order for X units of 4-factor PCC, which could range from 500 to 5,000, and have to pull all vials on hand and manually add up individual boxes to get as close as possible, defined as within 250 units below or 500 units of factor 9 above the actual dose ordered. Once they got within this range of units of factor 9, they then changed the order on the verification screen and prompted a second pharmacist verification. This caused significant delay in an already stressful environment. Once that step was complete, the vials were then sent to the IV room to be reconstituted and pooled into a single IV bag. The ED pilot was implemented in May 2018 as an effort to reduce timing of PCC administration, where we decided not to look at exact units of factor 9 and assume that there were 500 units of factor 9 per 20 ml vial of PCC, which allowed rounding of each dose to the closest 25 units. This was coupled with a single pharmacist verification and no active change to the dose ordered, and additionally eliminated the IV room step, where the vials were pulled and sent to the ED now for bedside reconstitution and administration through a syringe by the nurse at bedside, and this ensured that the drug in its entirety was administered to the patient. The objective of our study was to evaluate time to administration following the administration of 4-factor PCC after a change in dosing protocol and implementation of a bedside reconstitution in the emergency department. We're identifying significant delays in time from orders to administration as reflected in numerous safety reports. This was identified as a quality initiative project with a goal to reduce the time to administration. With this required was interdisciplinary process mapping and changes in the current workflow and implementation of a redesigned workflow pilot supporting this goal as described in the previous slide. But we additionally wanted to take it a step further and assess additional safety outcomes such as serious adverse events. This is a single-center retrospective pre- and post-pilot study including adult patients in the emergency department who received 4-factor PCC for reversal of anticoagulation. Patients were excluded if they were receiving 4-factor PCC for an indication other than reversal of anticoagulation. The primary outcome of this study was time to administration, further defined as time from order to administration of 4-factor PCC, comparing the pre- and post-pilot groups. Secondary outcomes included serious adverse events and mortality on admission. A subgroup analysis including patients requiring reversal for vitamin K antagonist-induced hemorrhage was additionally conducted. We predicted a 50% reduction in time from order to administration of 4-factor PCC with the implementation of this ED pilot. In order to determine power for the study, we used mean time from order to administration from a similar population of ICU patients that were otherwise excluded due to their location, and this accounted for about 32 patients. It was determined that we would need about 21 patients per arm to have an 80% power reduction in time, assuming a two-tailed t-test with alpha of 0.05. A student t-test was utilized for time to administration analysis, and chi-squared tests were utilized for all categorical data analysis using Microsoft Excel software. A total of 203 patients received PCC at our institution between November 2016 and May 2018. 94 patients were excluded as they did not receive PCC in the ED or if electronic documentation error occurred. This resulted in a pre-implementation group of about 67 patients, and data was collected on those patients who received PCC between November 2016 and May 2018, and our post-implementation group was data collected on patients receiving PCC from May 2018 to May 2019, and that accounted for 42 patients. Baseline characteristics were similar between the pre- and post-pilot groups. Some characteristics to point out: a majority of patients that were requiring reversal for those were within therapeutic range for anticoagulation, indicated by their baseline INR. Most patients requiring reversal were on an anticoagulant for atrial fibrillation, and the majority of patients' indication for reversal was intracranial hemorrhage. The patients labeled in the other groups under indication for reversal were indicated most often for reversal prior to surgery or an invasive procedure in which their INR was requested to be below 2. Of note, we did include data collection on patients who were requiring reversal of a factor Xa inhibitor, those being apixaban, rivaroxaban, or edoxaban. For our primary endpoint, mean time from order to administration was significantly reduced from 35 minutes to 25 minutes in the post-implementation group. This was about a 30% reduction from 35 minutes, but was more than a 50% reduction from 50 minutes within the ICU patients. Looking at secondary outcomes, the total number of events was reduced, with post-pilot patients experiencing less bleeding and thrombotic events. The only thrombotic event experienced post-pilot was DVT or PE within 30 days of administration of PCC. Bleeding was further defined as fatal or overt with a drop in hemoglobin of at least 2 grams per deciliter or requiring transfusion of at least 2 units of packed red blood cells or hemorrhage into critical anatomical site. Mortality is another endpoint that trended towards reduction following post-pilot implementation. However, our secondary endpoints our study was not powered to identify these secondary endpoints as significant differences. In our subgroup analysis of vitamin K antagonist associated reversal, we did see a reduction in thrombotic and bleeding events. However, the study was not powered to detect these within the subgroup analysis. There was no incidence of thrombotic events in this vitamin K antagonist subgroup, indicating that thrombotic events occurred in DOAC patients only in the post-implementation group. This data can help suggest that time less than 25 minutes is effective in reducing thrombotic and bleeding events in those utilizing PCC for reversal of vitamin K antagonist associated bleeding. So in conclusion, our dosing pilot showed a reduction in time to administration and total number of serious adverse events. And this suggests that changes in the administration protocol did not cause a significant increase in risk in rates of thrombotic or bleeding events, therefore not resulting in harm to the patient. We should additionally determine a time frame in which reversal agents may reduce risk for adverse effects and or mortality. There were many limitations to this study other than it being single center, so data was collected starting with patient information from 3 years ago, in which clinical practice has adapted and become much more familiar with use of PCC for reversal. We additionally would like to, or think there's a need to determine exactly when thrombotic events were happening with regards to restart of anticoagulation, if it was further out versus an immediate event post-PCC administration. And we would additionally like to further analyze the bleeding events that occurred. So next step for this study is to implement a hospital-wide bedside reconstitution and fixed dosing protocol of 4-factor PCC within our institution. And that concludes my presentation on the evaluation of time to administration of prothrombin complex concentrate following implementation of a dosing pilot. Thank you.